All right, good evening, everyone, and welcome to the Together We Build Imaging Services virtual town hall. This is the 10th in our series of conversations looking at 11 program-specific areas of planning for the new Windsor-Essex Acute Care Hospital. So before we begin tonight, let's respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Niswi, Ishkoden, Anishinaabe, the Three Fires Confederacy, Ojibwe, Ottawa, and Potawatomi. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation. So on behalf of the project management team overseeing stage 2 planning for the new hospital, we are pleased to welcome everybody joining us tonight via Zoom webinar. I'm Allison Johnson, Manager of Communications and Community Engagement for the project, and your moderator for this conversation. Tonight, you will have the opportunity to meet some members of the user group designing the diagnostic imaging spaces in the new hospital, learn about the work that they're doing, and ask questions. So to ask questions, which we encourage you to do at any time, click on the Q&A button at the bottom of your screen and type in your question. We will do our best to answer as many questions at the end of tonight's presentation. Please note the focus of this town hall is stage 2 planning of imaging services. This includes items related to the physical structure of the area, the layout of the rooms, what other programs and services will be located nearby, design features and design technologies. And to maintain the flow and focus of this conversation, please ensure that your questions are related to this topic. Following tonight's conversation, we also invite you to visit our engagement platform at togetherwebuild.wrh.on.ca, where you can ask further questions, take our surveys, and share any ideas that you have with the team. So I do want to introduce you now to tonight's panel guests. Tonight, we have Karen Riddell, Chief Operating Officer, Chief Nursing Executive, and Vice President of Critical Care, Cardiology, and Diagnostic Imaging Services. Dr. Del Genoa, Chief of Diagnostic Imaging. Colleen Nelson is Director of Diagnostic Imaging and Nuclear Medicine. Janet Fleming is our patient representative with this user group. Robert McEwen is a consultant with Agnew Peckham Healthcare Planning, and he's been working closely with this group. And Dr. Andrew Petrakis is the Director of Clinical Services Planning. Thanks everyone for joining us tonight. So before we get into tonight's conversation, I do want to talk for a minute about where we're at in the planning process. The capital planning process for building a new hospital is 5 stages, and we are currently in stage 2. So if you take a look at this chart, you will see that we started functional programming earlier this year. The functional program is a very detailed planning document that describes future services, activity volumes, staffing levels, new technologies, and space requirements. So since the beginning of the year, approximately 40 user groups representing different hospital programs and services have been working closely with Agnew Peckham and patient representatives to complete this step. As you can see, they're about halfway through that process, and when they're finished, they will work with a team of architects and engineers who will use the functional program to create a set of block schematic plans for the new building. So these are really early plans that show how the rooms will be organized throughout the hospital, both vertically and horizontally. So what other programs and services will be located nearby, and what other ones will be located directly above. So these will be completed by late fall, and a revised cost estimate is also part of stage 2. And you can see that this is scheduled to take place later this year. So everything will be submitted to the ministry in the early part of next year. And then we move into stage 3, where we get into more detailed planning and design development. So then we're ready to take the project to market. That happens in stage 4, and a detailed process is used to select a developer to further this design. The final stage is construction. That is stage 5. And if all goes well, we hope to see the first patients in the building by 2030. So again, we are still in the early stages here, but it is important to note that hospital leadership considers it very important, and those who are at the planning tables consider it very important that we have the opportunity to check in with all of you, share project highlights throughout the planning, and get your input. So thanks to everyone for being here with us tonight. And now let's begin with Dr. Petrakis. Dr. Petrakis, can you give us an overview of imaging services and where this fits into the bigger planning picture?
Great, thanks, Allison. Good evening, everyone. First of all, on behalf of the approximately 40 user groups, I'd like to welcome everyone here tonight for your comments, suggestions, and questions to help us in planning the new imaging services in the new hospital and at Willett campus. Just to remind everyone, the imaging services that we're talking about this evening, there's a bit of a list, so bear with me for a minute. General radiology, ultrasound, mammography, CT, MRI, PET scanning, nuclear medicine, bone density, and interventional procedures. So keep that in mind when you think of how we're going to plan all these services for the main hospital. Our functional planning group is working to ensure the main campus imaging department is located adjacent to the following services, which are quite important to be adjacent to: the emergency department. Hopefully this will be on the same floor, either immediately and next to the emergency department, or possibly with a satellite emergency department or a satellite imaging department within the emergency department itself. Vertically adjacent to the emergency department or to the diagnostic imaging department, critical care will be located in the inpatient med-surg units, and also important, cancer center and the ambulatory care clinics that will need radiology as well. When we consider outpatients, we'll have to implement strategies to ensure access to convenient parking, convenient access to the main entrance, have intuitive wayfinding to diagnostic imaging. All of these are factors that we have to consider when we do our planning. Thanks, Allison.
A lot to consider there. Thanks, Dr. Petrakis. And a question for Karen, if you can give us a bit of an overview and talk about the vision of this group when it comes to the future of diagnostic imaging at the new hospital.
Yeah, absolutely, Allison. Thank you. And thanks to everyone that has joined us this evening. It's so important to have not only our community members as part of our planning team, but also here with us tonight and working online to submit their questions. So I'm really excited to share our vision for imaging services for our community as part of this functional planning stage for the new hospital. Our vision is really to build an imaging program that is able to provide both timely and convenient access to state-of-the-art technology for both diagnosis and treatment for our community. And this new state-of-the-art hospital system is really going to allow us to consolidate many services, requiring less travel between sites for our patients and their families, and more timely access to care, and will also improve recruitment of medical professionals and allied health staff as well. So really exciting, and thank you again for joining us.
Thanks, Karen. And Colleen, over to you now. It's interesting. I've sat in on a couple of the user group meetings to hear everything that's discussed. And a lot of it is, standards, and a lot of it is based on what other hospitals have done. But when we bring that down to how it benefits patients, what are some of the conversations that are happening at the table, and how will this new hospital benefit patients?
Well, thank you, Allison, and good evening, everybody. As Dr. Petrakis alluded to, it's all about location, location, location. What we want to do is have all of our diagnostic imaging services located in one department. As Dr. Petrakis stated, it'll help them to be able to find their way to where they have to have their exam performed. And it'll also help with the wayfinding so that we'll be able to, take them directly to their appointments. We also want to talk about the separation of our inpatient and outpatient waiting rooms, but I'll let Robert discuss that more in his part of the presentation. For the staff, though, there are some interesting concepts that we're looking at where we want to share workspaces for the technologists that they're directly adjacent to the camera rooms. We feel that this will create some efficiencies and allow the staff to support one another when the assistance is required. It's also important that the camera rooms will be sized spaciously to support not only the imaging equipment, but they'll also be able to accommodate the ancillary staff who, may be needed to support the patient during the imaging process. As Karen had indicated, our goal is to have a state-of-the-art department with advanced technology that will benefit both the staff and the patients. And some of these benefits will include faster scanning times, shorter prep, and increased efficiencies. Thank you, Allison.
Thank you, and a lot to look forward to there. Dr. Denoa, when you're at the planning tables, what are some of the important considerations that your team has top of mind when working on this?
Yeah, thanks for the question, Allison, and good evening, everyone. Thank you for joining us. Top of mind is definitely the patient experience. What we're looking at doing is building a plan, a functional plan for the hospital that's centered around the patient and what they experience when they come into the diagnostic imaging department and the hospital as a whole. So what does the patient want? What are their needs? How can we service them better? How can we minimize their moving around the hospital and around the department? How can DI come to them to give them the answers that they need to help them in their journey? That's one of the major factors that we're looking at when we're meeting. We're also looking at picking the best equipment and the most logical, sensible plan for the architectures to build this new hospital. And of course, as Colleen stated, we do want the most advanced equipment that we can provide to help our physicians and nurses and technologists give the best care that they can to our community. Thanks, Allison.
Thanks. On that note, a question for Karen. When we're moving into the new hospital, are we looking at all new equipment, or will some equipment be coming with us from the current facilities?
Yeah, that's a great question, Allison. Based on what we're currently using and the time frame for the new hospital opening, it's one of those things we're going to have to see where that equipment is in its lifespan. So some pieces of equipment might have a 10-year or 15-year lifespan. And depending upon where it's situated at the time that we're ready to move into the facility, we'd be making decisions around whether we're going to procure new equipment to replace it or would be moving that equipment. Some equipment, of course, is very easy to move. So some of the more portable, we'll call it portable, but they're all heavy pieces of equipment in DI. So things like ultrasound machines might be very easy to move to the new facility, and some pieces of equipment such as, CAT scans and MRIs are much more complex move that's associated for them. So all of that will be taken into consideration as we're planning to outfit the new hospital, because we know, of course, how old all of our equipment is now, where it's at in its life cycle. We are continually replacing equipment. So we are obviously bringing in new equipment before we open the new hospital, and we'll gauge that as we get closer to that planning stage.
Thanks, Karen. And it's interesting, we were talking about this earlier today, how hospitals make that move and all of the things that you have to consider. And it's almost like once you're done planning the hospital and what it will look like and construction takes over, then you have to start immediately planning, how are we going to make this move? How are we going to move equipment? How are we going to train staff so that they're up to date on what the new facilities like and the workflow when we move in there? So interesting. And those are conversations still to come for sure. And throughout this planning stage, the user groups are working closely with consultants from Agnew Peckham Healthcare Planning. They've been part of many of the largest and the most recent new hospital projects in Ontario and across the country. And Robert McEwen has been working closely with this user group. And tonight, he's going to share some highlights from their work, as well as some trends that his team is seeing in imaging services planning at other new hospitals. Robert?
Great. Thank you, Allison, and good evening, everyone. Just going to share my screen with a brief presentation here on some of the findings from our diagnostic imaging planning so far. Just to root everyone in the foundation of good hospital planning, we love the expression form follows function. So the facilities that we plan have to function at a high level to deliver safe and efficient care, and also work for the staff, the people providing that care. With diagnostic imaging in particular, we need to think about significant changes to healthcare practices, technology, and equipment over time, and combine both of those considerations together to really design a future imaging department that is going to work well or work excellently for patients and staff. In terms of some of the content that we get into the stage 2 functional program, we define the services at the new hospital and at the ULET campus going forward. Dr. Petrakis has already listed off the wide variety of imaging modalities that are addressed in the imaging functional program. We consider things like workload, key staff flow, patient flow, Adjacencies, we've spoken a lot about adjacencies. Who else in the hospital does diagnostic imaging need to be close to? Probably one of the most important adjacencies when it comes to diagnostic imaging is being immediately adjacent to the emergency department to support trauma patients or any patients for that matter presenting to the emergency department with a dire need for diagnostic imaging services. Also in the functional program, we create detailed space lists, and this really defines all of the patient waiting areas, change areas, prep spaces, imaging rooms that will be in the department in the future. And we're doing this for 2 planning timeframes. So we're looking out 10 years from now and 20 years out from now to ensure that there's a future flexibility strategy to grow the hospital beyond opening day. All of this information feeds into the preliminary architectural block schematics that we'll be working with an architectural team to create on behalf of the hospital. So if the slide is a little bit repetitive, but again, it just really gets into some of the details that we develop in the functional program, the services provided, some of those key workflows that I spoke about on the previous slide, the actual current and projected visits, the number of exams that are occurring at Windsor Regional Hospital today, and the projected visits that will be occurring at the new hospital in the future. That helps inform the number of imaging rooms that we need to plan for at the future hospital. In terms of staffing, we also need to take into account the number of people occupying and working in this space to ensure that they're well equipped with proper staff facilities, washrooms, other considerations. In terms of some of the technical planning and design requirements, we've spoken a bit about the adjacencies already. We also get into a level of granularity where we describe to the architects how we want the actual imaging modalities to be organized. And so Colleen alluded to this a little bit earlier in the presentation, but we, to the extent possible, we want really, really robust separation of routine outpatients coming for diagnostics from those acute inpatients or emergency department patients who, generally speaking, are more acutely ill, might be on a stretcher and don't want to be transported through a highly public area with lots of other ambulatory patients. Lastly, there's the space allocation. Again, what are the rooms required in imaging of the imaging department of the future? How many of them and how big? In terms of some of the planning trends for diagnostic imaging in particular, so I just spoke about that front of house orientation for routine outpatients versus the back of house, more discrete circulation routes, patient prep areas for those inpatients and emergency department patients who are more, generally speaking, more acutely ill. We take infection prevention and control considerations very, very seriously when we're planning the department of all areas of the hospital in the future. So that's a key consideration. In terms of operational efficiency and flexibility, Colleen actually spoke to this one as well, where we have this concept of creating shared control rooms situated in between imaging rooms. And what that really allows for is for staff to be in close proximity of one another, to cover each other's scanning rooms if they need to, and also help one another with facilitating patient flow through those imaging rooms. So that's a great design feature that we'll be incorporating in our functional planning exercise. Lastly, this all funnels down into really excellent patient and family-centered care. So these are all a trend, an absolute top of mind planning consideration when we undertake this work. Just a couple of sub notes here to point out for imaging in particular. The amount of minimally invasive image guided procedures has really skyrocketed exponentially over the last 10 plus years, 20 years. And so we certainly want to make sure that we are taking these types of procedures into account when we're planning the diagnostic imaging area of the future. Minimally invasive, it's not quite as an invasive procedure as an open surgical procedure. So there are huge benefits associated with minimally invasive procedures and that type of approach. And again, we want to make the path of travel from the emergency department to diagnostic imaging services as short as possible for those patients requiring emergent imaging. Lastly, this is just a high-level schematic of the concept that we've talked about throughout, where we are going to have various imaging modalities adjacent to one another. We have a fairly routine outpatient entrance for patients coming for their scheduled exams from home, but then we also have back of house entrances in each of these imaging areas to facilitate private and discrete inpatient and emergency department patient flow. So a very high level schematic here, but really demonstrates the patient experience that we want to achieve in the future. And with that, Allison, that is all from me. So I'll turn it back to you to keep the discussion going.
Great. Thanks so much, Robert. And I do want to encourage all of those in attendance tonight. If you have any questions for our panelists, please submit them now. To do that, click on the Q&A button at the bottom of your screen and let us know what you're interested in learning more about tonight. Right now, we're going to check in with our patient representative, Janet Fleming. She's been sitting in with this user group participating in the planning process. And Janet, what are the most important factors from your perspective to consider when doing this functional programming?
Well, thank you, Allison. But first, I want to thank Windsor Regional for letting me be part of the conversation for the imaging department. The most important consideration for me is location and ease of access to all the departments that'll utilize imaging. As a cancer patient, I was humiliated walking in a skinny Johnny shirt from ultrasound to the other end of the hospital for surgery. Another time when I broke my ankle and had trouble mastering crutches, it was frightening trying to maneuver through the hospital corridors from one end to the other. Knowing that imaging will be on the first floor and close to parking solves a lot of the problems I've had in the past. I've been amazingly thrilled with the thought and detail that has been put into the planning for all the hospital. Knowing the square footage of the chairs and beds, etc., used in each department, and statistically how many people will be using these items at any given time. It's been just an amazing process. I wish more people in the community would take the time to voice their opinions, because I know I'm not the only one who has suffered the embarrassment and inconvenience that we've had in the past, and really excited about joining on into the future.
Thank you so much. And we have a bit of extra time, so if you don't mind, I want to ask you, how have you found the process to be, being at the table with people from, you've got planning experts, you've got medical experts. What's it like having these conversations?
Oh, it's absolutely amazing. I just can't believe the detail, and everything is being thought out, where I just wanted them to move as to where it would be convenient for me. But even little things like sitting in the waiting room in a Johnny shirt, kind of in a main hallway, has been considered. How can we move so the patients aren't inconvenienced, embarrassed, and just comfortable in the situation they're in.
We appreciate you being there. And I do want to mention, we wish that we could have everybody at these planning tables, but they're not big enough. That's why we're doing this. We have these conversations. We also have an engagement platform set up in each of the areas that we've been talking about throughout these town halls. We're encouraging you to visit, to share your ideas, your suggestions, take our surveys. And again, if you have any further questions, you have the opportunity to ask there as well. I'm going to give a shout out one more time. Put your questions in the chat box. One question I see here, actually, we have a question that I'm going to direct to Robert. The question is, can you elaborate on how projected or predicted volumes are determined for general functional planning? Is it current volumes or population growth, etc.?
So the volume projection methodology is really based on the population growth and aging of your regional catchment area. So that's the major driver of the projected volumes. The ministry does require that we include current volumes in the functional program as part of the stage 2 planning submission. So that's why we have to show both current and projected volumes. But absolutely, when we're looking out 10 and 20 years, we are planning on the projected volumes for those planning horizons.
Thanks, Robert. So we don't have any further questions. We do have some suggestions that people have been posting, and we appreciate that. We will take those and include them with the package that we're preparing and we'll share with the user groups before the end of this part of the process. But if anybody has any other questions, please submit them now. And in the meantime, we'll check in with our panelists to see if anybody else has anything to add to the conversation. I think we've had some really good conversations over the course of the last 3 weeks. And this conversation started even earlier this year when we went out to the community with the survey, and we heard from community members. We had close to 1,000 people reply, and they said a lot of the same things that we're hearing here, that we're hearing on the site. One of our patients said it last night very well. We want it to be easy and we want it to be convenient. And whether that's parking or large spaces or good wayfinding, all of the things that the teams will be considering, and all things that we will keep top of mind throughout the planning process. So once again, I'm not going to let everyone leave without mentioning again, please visit our website, togetherwebuild.wrh.on.ca. Provide your input. Look at the 10 other planning areas that we have been soliciting feedback on. This includes public spaces, pediatrics, inpatient units, and more. You can ask questions. Later this year, we're going to do this all again. So following the town halls, that website will remain up for another month. After that, we're going to package the information. We will share it with individuals in this user group, and then we'll also make it public. And that information will help guide decision-making, not just in this stage, but throughout the process. So we really do appreciate it, and it really is important. We hope you'll join us back here tomorrow night. Tomorrow is the final in our town hall series, and tomorrow night we're talking about the future of public spaces. So that includes everything from the gift shop, the spiritual services, to the Main Street, as they describe it, that links those services to other parts of the hospital. We hope that we'll see you tomorrow. Thank you to everyone who joined us. Thank you to everyone who's participated so far. And a huge thanks to our panelists for everything that you do in the user groups, for being here tonight, everything you do in the hospital and in the community. And for the final word of the night, we did a quick coin toss at the beginning, and Dr. Del Danoa won the final words of tonight. So Dr. Danoa?
Yeah, I just want to say, the energy is palpable throughout the hallways of the hospital. We're so excited about this development. The team here has done so much great work, and there's so much more work to come. But most importantly, as Allison said, people like Janet Fleming and yourselves out there, we need your energy. We need your input. There's so much media and opportunities for you to provide us great feedback to help steer this ship so that we have the best hospital in the province. So thanks again for everyone for all your energy. And we're having a wonderful, wonderful time building and working together on this new project. Thanks.
Thanks, Dr. Danoa. Thanks, everybody. Have a good night. Bye-bye.
Thanks, everyone. Night.